my name is Andrew. I'm a third-year medical student at the University of South Carolina. Today, we're going to be talking a little bit about cefazolin or cefazolin and surgically treated acute appendicitis. We're going to be asking when, where, and why. It's funny, I've always called it cefazolin, and I got roasted by my pharmaceutical colleagues in the MICU a couple months ago. They were like, what even is that? I was like, cefazolin. They're like, cefazolin? I was like, that does sound a lot better. So I'll probably say both ways, but for now, I'll try to sound smart and say cefazolin. Before we get started, thank you very much to SMA for having me, and thank you very much to my mentor and the PI for this project, Dr. Kevin Schuster out of Yale School of Medicine. He's been instrumental every step of the way for this project. So some learning objectives, we're going to start by discussing what is a surgical site infection. We'll then discuss kind of the burden on the healthcare system that it places. Next, we'll review some current preoperative antibiotic guidelines, and we'll end with a discussion on the antibiotic resistance epidemic and its trajectory. So before we get started, because I know everyone in here loves questions, this one's hopefully by the end of this presentation, we'll have an easy answer. Which of the following correctly defines the current recommendations for preoperative antibiotics for surgical procedures involving the GI tract? And here we have our array of answers. So no spoilers, we'll get to it at the end. A little bit of background. So to have this discussion, let's first talk about what a surgical site infection is. ACS defines this as an infection occurring within 30 days of operation at the site of operation and involving either purulence, positive cultures, or anything infectious as in like redness, swelling, drainage. There are different types of surgical site infections. You have your superficial, which is just your skin, your subcutaneous tissues. Then you have deep, which involves your fascia, your muscle. And then we have organ space, which involves your, well, organs. And in this case, the appendix. So why do we care? And a ton of research has gone into looking at the burden that surgical site infections place on the healthcare system. And overwhelmingly, we know that surgical site infections are associated with increased rates of rehospitalizations, increased rates of reoperations, which leads to overall total increased cost of care and increased morbidity, mortality for our patients. So all in all, just very bad, which logically makes sense. So many committees have come out with guidelines dictating preoperative antibiotics with the goal of if we can give antibiotics right before incision, maybe we can decrease the rates of infections after operation in our patients. This started with WHO in 2008 and was supported by SIS in 2013 and ACS in 2016. And they all recommended preoperative cefazolin within 60 minutes of incision. So now let's talk about the situation that kind of led to this project. You have a patient that comes in with, let's say, generalized abdominal pain. They say it kind of started around the umbilicus and has migrated to the right lower quadrant. They go to the ER where they're worked up and found to have acute appendicitis. The next step most likely will be moving to the OR for an emergency appendectomy, most likely laparoscopic. Now, based on what we just talked about, they will probably get that preoperative dose of cefazolin to decrease their chance of post-op surgical site infections. However, if you've ever been in the emergency department, you realize this process isn't quite as streamlined. Oftentimes, we find that our patients are in the emergency department for several hours, and what happens is they get antibiotics while they wait in the emergency department for surgery. So this led us to think, well, if they're getting broad-spectrum antibiotics in the emergency department, do they still benefit from this additional preoperative dose of cefazolin? And so we looked into it, and we asked the question, for these patients who got antibiotics in the emergency department, does the additional dose of preoperative cefazolin, or cefazolin, there it is, decrease their chance of getting a surgical site infection? So how did we study this? We ran a retrospective cohort study involving over 1,300 patients from a single institution from the times of 2013 to 2020. We categorized them based on their antibiotic categories, what antibiotics they received. So in the ED, did they get antibiotics? And if they did, was it narrow spectrum or broad spectrum? Broad spectrum meaning it covered your anaerobes and your gram-negatives, which we know like to live in the belly. And preoperative antibiotics, did they get that dose of cefazolin or not? Variables that we considered include age, sex, perforation of the appendix, BMI, a comorbidity index score, surgical approach, so was it laparoscopic or open, and then their antibiotic categories. Our primary outcomes that we were interested in were superficial or deep surgical site infections, which we grouped together just based on coding, and organ space surgical site infections. So what did we find? Of our patients, they had a mean age of about 40 years old, and 40% were females. For the variables that were found to be predictive of surgical site infections, we found our older patients were more likely to sustain SSIs. Interestingly, we found that males sustained SSIs at a higher rate than females, and then perforation of an appendix was predictive of surgical site infections, as well as higher comorbidity index scores and higher BMIs, which again makes sense with what we know based on literature. Interestingly, though, we found that ED, broad-spectrum antibiotics, were associated with lower incidence of surgical site infections. However, that additional dose of preoperative cefazolin or cefazolin was not. So this, bringing it back to our beautiful diagram, led us to conclude that in patients who get that emergency department antibiotics, they don't benefit from the additional preoperative dose of cefazolin. So that's all really well and great. Hypothesis was proven correct, but why does that matter? And to kind of explain why it matters, let's talk about some interesting statistics. So approximately 15% of all antibiotics in the hospital setting, in the inpatient setting, are given for surgical prophylaxis. Now, combine this with the fact that emergency appendectomy is one of the most common procedures done, with about 300,000 per year in the United States. Quick math would lead you to believe that's potentially 100,000 doses of preoperative or prophylactic cefazolin that is not beneficial to our patients. Now, contrast this or consider this in the setting of what we all know if you're involved in healthcare, and that is the antibiotic resistance epidemic. We're giving hundreds of thousands of doses of preoperative cefazolin that's not beneficial in the midst of a sweeping antibiotic resistance epidemic. And so I think these diagrams do a good job of explaining what we already know. You can see on the right side, the amount of resistant enzymes that we're finding is increasing at an exponential rate, and some of our big gun antibiotics are becoming less and less effective. And so I think it is incumbent upon all of us as healthcare providers or researchers or just really anyone associated with healthcare to kind of take a step back and look at opportunities to find antibiotics that are not benefiting our patients and really study it. And I think that's what is so special about this project, is that's exactly what we did. And it's a great example of, you're in the clinic and you're like, logically, it doesn't make sense that we're giving these antibiotics. I know you could probably think of something that you've come across in your day-to-day. And then it's taking it a step further and actually looking into it, doing that study and say, well, logically, it doesn't make sense. Let's see what we find when we look into it. Because I think that really is our biggest weapon against the antibiotic resistance epidemic. It's limiting the administration of unnecessary antibiotics or antibiotics that are not benefiting our patients. So returning back to our pop question, which of the following is the correct preoperative antibiotics to give for our patients with surgical procedures involving the GI tract? We now know that that is B, cefazolin, within 60 minutes of incision. And these are my references. Thank you for your time. Happy to entertain any questions. Mm-hmm. So, yeah, that is a great question. So we compared people who just got the ED antibiotics and no cefazolin to the people who got ED antibiotics and cefazolin. And that was where we made the conclusion that if they had gotten the ED antibiotics and cefazolin, it was no different from the people who had just gotten ED antibiotics, proving that that additional dose of cefazolin was not beneficial. We did find, however, that if they did not get ED antibiotics, the preoperative cefazolin was beneficial. But based on our direction of the study, and for the purposes of this was 10 minutes, I didn't want to go down that rabbit hole. But yeah, good question. So that's a great question. And that's kind of where we're headed now. Right now, we're in the, I'm sure all of you know, the monotonous process of going back and forth with, different editors like, oh, we'll look into this variable. And so right now we're actually looking into, does the timing of the ED antibiotics make a difference? So we proved that if they got broad spectrum ED antibiotics, that was good enough. But does it matter if it happened within 2 hours, or if they sat in the emergency department for 7 or 8 hours? Is now that still effective? So that's kind of where we're at right now, and I think that's kind of the last variable that they wanted to see us like really look into and dig into before they make any type of policy change. Yeah. Mhm. So for the purposes of, controlling for variables, cases that had to be converted to open were excluded. Because then you run the risk of, now you've got skin microbes that you have to account for. Those are generally longer procedures, so they're going to get more intra-operative antibiotics. And at that point, there's too many variables to reasonably make good conclusions, and we already had a large enough sample size for our power, so we excluded those and felt comfortable doing so. Awesome. Thank you very much.